as indicated, my name is Willo. I'm with CEPI here in Brussels. We have offices in London, in Oslo, and in Washington, DC, but we're mostly working in LMIC countries. We work in Africa, Latin America, and Asia, especially on diseases of pandemic nature, and that's obviously an important topic for today. I would like to thank the Coalition for Life Course Immunization and MSD for hosting us. I hope you wouldn't mind that I'm going to use an example which is not from MSD, but I'm just going to see that mouse. There we are. Very briefly, CEPI was started in 2016, 2017 after the Ebola outbreaks as a sort of a key agency from a public health perspective to help think about pandemic tools, mainly vaccines. Vaccines has been our main part of the work. And obviously, after COVID, life changed dramatically. Our initial focus was really on low middle income countries, thinking about the disease like Ebola outbreaks in West Africa and in other parts of Africa. But we realized, all of us, although I think many people seem to want to forget the lessons from COVID, that this is an area where there's the global connectiveness, which is really what we're talking about today in terms of transport, in terms of travel, is essential. So our focus has sort of shifted a bit more in a global fashion. In terms of our vaccine development, the big driver of our strategy, which we call CEPI 2.0, which is our second 5-year strategic period, is the 100-day mission. And this is the question we've asked ourselves. It's not just good enough to look at dengue or to chikungunya or into something like corona, but really the question is, if there's a new disease breaking out, are we ready to quickly transform, to have vaccines quickly developed to avoid that an outbreak and a local outbreak becomes a pandemic, or even worse, an endemic situation, as we discussed today. And the idea is that from the moment of a detection of a new viral entity, that within 100 days, we would have a vaccine both ready, approved, and ready for introduction at scale. That seems crazy if you were involved before COVID in this, where 10, 20 years of development was the norm. But as we have seen in COVID, we managed to do this in about 300 and a bit days. So the question is really, can we make that even more so? We did some recent modeling that if 100 days mission would have been successful for corona, we would have been having a vaccine by April, and that was when there was about 3 million people detected with corona. By the time we got the virus, at that time, we were already at more than 90 million. So the impact of such a mission needs to be obvious. Is it doable? That's then the question. And the answer, I think, to us is obviously yes. But for today, and the focus I want to take is that even though we now have a global vision, equitable access for the world is essential to our mission, right? So what does that mean? That means that if we have the vaccines, and we've seen that again by COVID really going out of hand, it's nice if we have this in Europe and we can be protected. If we really want to be protected, we need global protection. We need everyone to have that access. So questions on why would we vaccinate the whole of Europe first, including everyone who's not at risk, and keep people at high risk in Africa and Latin America exposed, because that basically continues the cycle of infections. And what it also does is it gives viruses the chance to adapt and create all the different versions to which we then have to start the whole fight again. What do we do in that area? We, for instance, work with manufacturers. We work with, like MSD, we work with Valneva, we work with others to say, can we work together? And depending on the market conditions, can we provide the additional support that makes this a global product, a global public health product that is available for everyone? And I'll come back to that for a little bit. We are therefore a donor. We are funded mostly by our member state partners. There's the European Commission, there's 10 European Union governments, there's Japan, which is one of our major donors, but also Brazil has recently joined us, Rwanda, Indonesia. So we are one of the first agencies in this way that is not just funded from, let's say, high-income countries, but is really truly more of a global partnership with global investments. And therefore, we only work with partners who commit to this principle. Now, how that principle gets implemented, we can talk about it a little bit more. But the question was a little bit about surveillance. And one of the things that we found, needing to stress that surveillance is essential to CEPI, but it's not part really of our mandate, and our board sees this as an enabling factor. And people like the ECDCs of this world, Africa CDC, PAHO, are essential to us. So we support them. We don't have this as our primary goal. But what we do is, and examples are Lassa fever outbreaks in West Africa. We've done this for Ebola. We've done this for Marburg. But we've also done this for chikungunya, which was mentioned. EPI studies to really understand the actual size of the outbreaks, especially in LMICs. And what we have found is that in most of the diseases, the reported outbreaks are really significantly smaller than the actual burden of disease. And that is a number of cases. In chikungunya, for instance, there tends to be a strong overlap with malaria endemic areas. So we find that a lot of people are basically effectively, based on symptoms, identified with a disease like malaria. They're given either antibiotics, which obviously would be of no use whatsoever, or a malaria treatment. And because most people who have a strong immune system can probably be recovering within a week to 2 weeks, and therefore people think that this identification of disease and treatment has been successful. However, chikungunya is not very deadly, and therefore also attracts a little bit less attention than some other diseases. But it's a disease that can be really harmful, especially for young children. And therefore, one of the things that we also identify is that there's a lot of underreporting, especially in women and pregnant women and in children, because those tend to not always be equally paid attention to in surveillance and in reporting systems. And one of the things that's important to us, and I think important for the discussion today, is chikungunya is in a way a good example, because we have now got a vaccine that's approved in Europe and North America and is about to be readily available in Africa and India through partnerships and tech transfers of the Valneva, the company that produced this. But as in many cases, the vaccine was developed and approved with data only looking at adults. So it's not yet available for children. It has not been tested in pregnant women. And this is an area where CEPI then invests. These are areas that are very hard to invest in from an economic point of view in companies. And we want to work together with the owners of the vaccine, with the developers of the vaccine, to ensure that those data gaps are filled. But you can imagine, if the biggest burden of disease of chikungunya is in children and pregnant women, even though we have a vaccine now, we should celebrate that success. We're really not going to be much further in controlling that outbreak. Now, this really is not needed, because my colleague next to me has just gone deeply through that. The fact that the likelihood of local transmission, as was neatly laid out, has grown and has become significant. The reason, of course, still is that there is an endemic situation in countries where a lot of travel to Europe takes place from. So we already discussed what we need to do to protect ourselves on this side from importing the disease. What CEPI's point of view is, of course, and what our focus is how can we work with endemic areas to significantly reduce the risk there. This is also in the interest of industry, because it means that you have a significantly larger market than just a traveler's market. You have a big interest from governments in endemic areas, let's say Brazil and India in chikungunya, because the economic impact of this disease is massive. As it is a chronic disease, it is really significantly impacting economic presentation in these countries. Obviously, we're very clearly, when you can roll out a vaccine like this, the individuals are significantly better off if we can have a safe vaccine available. This map is the same map, so I can safely skip this. And just to give you an idea, what we have done as CEPI is working with Valneva, who's the originator, and 2 other companies that are currently developing chikungunya vaccines as well. We have connected them to manufacturers in Brazil, and we're looking at other areas around the world to support them to create a tech transfer to make those available. We have done subpopulation studies, so looking at children. We have an ongoing study in children below the age of 12. We have studies lining up for pregnant women. We also support companies to do demand modeling. So this is where epidemiology comes in. This is where we're looking at underreporting of the disease in endemic areas. We also look at some of those outbreaks, not from a surveillance point of view, but really about what are the right tools. One of the things I found interesting receiving my own briefing on this event is that with the mosquitoes, there tends to be seasons. If chikungunya really picks on, the mosquito can bring out chikungunya. It's the same mosquito that does dengue. And as far as I understand, there's a seasonal pattern in that. So we need to think about what diseases do we vaccinate against. And then maybe finally on the number of surveillance. I mean, Brazil, you mentioned the outbreak of chikungunya and dengue. And you mentioned, what was it, 200 cases. Brazil at the G20, I think, just reported that they have about 1 million. Yes, exactly. 1 million cases in Brazil only. And you can imagine that's a very popular area to travel to. So the amount of risk to import, I mean, the numbers are even actually quite small, thinking about the fact that there's 1 million cases. This season has been especially brutal in Brazil. So it's also chikungunya, also dengue, and also Zika, which also all present in a very similar way initially. That's why the surveillance is so hard. Sorry, that's not the one. So take-home messages. We are highly connected, that is clear. What we think is that we need to work together to protect travelers, to avoid that disease can travel, which is essential as we talk about today. And that at the same time, we make those vaccines that are required also available in an endemic area to reduce the risk in itself in the beginning. Many of these vaccines that we'll have, and our colleague, Dr. Lucano, will talk about vaccine development in a moment. Even if we get an approved vaccine, like for chikungunya, they are often based on phase 2 data and on models. And what we want to do is actually bring them with real world evidence and actually introduce those in studies in places like Brazil and India, for instance, so we can get real world evidence on the effectiveness of the vaccine and help develop future more potent vaccines. As I had mentioned, working together on safety and efficacy studies is essential in a public-private partnership manner. And we really want to work with everyone to do that. And obviously, when we talk about surveillance, we want to have support for surveillance to really identify those differentiations that I mentioned, so that especially in areas, for instance, in Africa and Asia, and for other disease combinations in Latin America, we don't mistaken patients with the wrong disease and therefore have the wrong vaccination strategies. And as I said, in the end, it is really, I mean, we can keep 1 million cases going in Brazil, and then we can keep importing them. However good our surveillance system is, it will just be very expensive to do because we'll know we import them. So vaccination is essential, and working together globally to invest in equal opportunities for people to be safe is essential. So I'll keep it there. Thank you.